Good morning, everybody. Thank you for that lovely introduction. I'd like to thank Dr. Alexander and the committee for allowing me to present. I had the honor when I was working in the UAE, my clinical background for many, many years was mostly in trauma, and through a series of events, I ended up being the CNO of a maternal child hospital in the UAE, and this is where I did my doctoral project. And I am proud to say that I am considered by my colleagues in that hospital as an honorary midwife. So, although I spent many years in trauma, I see midwives as warriors. So I'm grateful for the opportunity that I had there. When I was doing my doctorate, it was a clinical doctorate, and the university really encouraged us to focus our research on a clinical evidence-based guideline and project that would improve practice. And so that's where this particular project was born. So I'll just tell you a little bit about how that transpired. So in the UAE, we had, when I was in the UAE, one of the highest rates of diabetes in the world. Actually, we're in competition in Northern Africa and the Middle East. There's a very high incidence of diabetes, and followed by Caribbean population. And so there are some parallels, and I'm hoping that you guys will see that as I present it. The prevalence of gestational diabetes in the UAE was 34%. So imagine that almost 1/3 of our mothers that presented with gestational diabetes. And when we did some original data gathering actually around putting together a clinical practice guideline for Joint Commission, our original audit showed us that we were very much behind the international benchmark as far as the treatment of our women with GDM. So internationally, the expectation is that only 30% of women with GDM will progress to medication. So oral hypoglycemics or insulin. And in our case, it was 70%. So our statistics were very poor, and it was that original audit that led to a multidisciplinary task force, and I will always be very, very grateful to the obstetricians that I worked with who were very, very open to us standardizing our guidelines for our treatment of GDM and moving forward on this multidisciplinary project. So we, at the time that we implemented the project, did not have any kind of interdisciplinary work going on around the treatment of GDM, nor did we have a standardized guideline that all the physicians followed. And so this was the progression of the project. So where the heck is what I'm talking about? So most of you, when you think of the UAE, you think of Dubai, and you can see the map. On the one side is the map of the UAE bordered by Oman and by Saudi Arabia. And like I say, Dubai is very familiar to people, but actually the largest emirate is the Emirate of Abu Dhabi. And the region of Al-Ain, which you can see in the green, is where I worked. It actually is an area that has 600,000 people, so it's not really what I would consider as a Canadian, anyway, rural. But its foundation is actually in a Bedouin population. The area of Al-Ain, as you can see on the other side, where you see the picture, is actually a natural oasis in the middle of the desert. And so at the time before oil in the UAE, many, many people traveled there, especially in the summers when it was hot. And it has a mammoth network of underground springs that provide fresh water, and it's the only place in the emirate where that happens. So as you can imagine, when we talk about the prevalence of diabetes, and also when we talk about, I'll talk a lot about BMI and the incidence of obesity in the UAE in general and in that area. When oil was discovered in the 70s, over a period of just 30 years, this country went from being Bedouins in the desert, moving from place to place, and in very many cases, almost a subsistence level of living, to incredible wealth and technology and fast food. And that's where a lot of the problems started. So the background at the site, like I say, the UAE has the highest prevalence of diabetes in the world, or it did at that time. It was been in competition back and forth, unfortunately. But the other thing that was happening in our community was that about 40% of our women who did have gestational diabetes were not even diagnosed with it till very late in their pregnancy, or possibly even when they presented for delivery, and did not actually get any kind of proper antenatal care for GDM. We've had the issue raised here about insurance in the Caymans. The government of the UAE made the decision in 2018 that the World Health Organization standard for antenatal care was that all women would be seen 4 times in the trajectory of their pregnancy. That's the expectation by WHO. And the UAE government committed, regardless of insurance, to all women having those 4 visits paid for. So, yeah, it was really an amazing initiative, but the point was that we weren't getting compliance with those antenatal visits, even though insurance was not a barrier. So we had to look at doing something completely different. So the hospital that I worked at, the project site, okay, why is it not going? Okay, but the project site I worked at, you can see it was established by 2 Christian American missionaries in the 1960s, long before oil. At that time, Sheikh Zayed, who was the ruling leader of the country, asked the Kennedys to come because the maternal mortality at that time was 50%. So 1 in 2 women died in childbirth, and so he recruited the Kennedys to come, and their legacy still stands. You can see the new hospital that was funded by the Sheikh and opened in 2014, which is the hospital that I worked at, but it had very humble beginnings. So at this project site, we delivered between 350 and 400 women a month. And our antenatal clinic saw around 200 patients a day. So it was a very, very busy site and provided some really good opportunity for us to make change. So we had 2 issues. One was the compliance with antenatal care and women coming in to be cared for. And one of the things that they really talked about was the time constraint of being expected to come to multiple appointments and see multiple practitioners. And as well, we did not have an integrated model. So there was no diabetic nurse who was involved in the GDM care. And also, we did not have, the dietitian was also a completely separate appointment, and our patients complained about that a lot. So we sort of had 2 stages. Like I say, the first one was the commitment to the National Institute for Healthcare Excellence guidelines, which were written in 2020. And then the foundations of our integrated clinic came from sections 1.2 and 1.3 of those guidelines that recommend that we include a registered nurse who would provide the education around glucose management, and our dietitian and physicians, our dietitian providing obviously dietary counseling, and then also the patients saw both the OB and the internal medicine in one visit. And so again, there was focus on lifestyle modification, diet, all of those different kind of things. So the impact of addressing the problem, this is what we were hoping for when we started. I'll talk a little, just tiny bit more about the literature, but blood glucose control is key to improved outcomes. So women needed to know how to measure it, how to control it, how to work with diet and lifestyle change in order to make those modifications. Definitely, there is a huge international focus on glucose control and GDM management in maternal health across the world. And when we look at the literature, we could see clearly that that model increased the success of women being compliant with lifestyle management and glucose control. So when we looked at the literature, the search strategy started with a general investigation of GDM and sort of the incidence and prevalence across the world, and then narrowed to explore the impact of a multidisciplinary model. And then finally, there were a few studies that had been done in the Middle East, but not specifically on the implementation of this kind of model. So we looked at the incidence and precedence. We looked, I'm sure in this room, people are well acquainted with the complications and outcomes of GDM and the fact that we see an increase in perinatal mortality, increase in maternal depression, preeclampsia, basically increase in C-section rate. And then we looked at evidence-based guidelines that were open to us and how we could implement an integrated model. I'm going to talk really super briefly about this for the nurses in the room. But it was Orm's self-care model that was the underground conceptual model for this study. And she's done a lot of work looking at empowering patients and how we can provide systems and information that allow women to control their own health. And a couple things, I just want to point out one or two things that were challenges for us, so we sort of had to do adaptation of the model. One obviously is the huge range of languages that we were dealing with. If anybody knows about this in the Middle East, Arabic is not Arabic. And we looked after Arabs from many, many, many different countries as well. We had Filipino and large prevalence of Filipino and Indian patients. And so language was a particular challenge for us. And then the other two things that I just wanted to point out is insurance was not an issue for us. And the second thing is, although the Arab, particularly the Arab culture, is a very paternal culture, it also drives women supporting women. So when we were in these integrated clinics, we were lucky enough to often have sisters, mothers, grandmothers, all sorts of people that were going to support women in this journey. So it really helped us with the teaching. Methodology I'll go through just really quickly. It was a quasi-experimental before and after design. We had been collecting data for a long time, but for the purposes of this project, we did do a 3-month view before we implemented the clinic, and then a 3-month view after we implemented the clinic. And it wasn't a randomized sample, but it was a calculated convenience sample that allowed us to hope for a statistical significance in what we were doing. So we looked at the inclusion of newly diagnosed GDM patients who attended 2 or more appointments in the first 12 weeks of the implementation of the project, and I'll talk just a little bit more about that afterwards. So we did a before and after design. The data was collected using ICD-10 codes through our electronic medical records. So we coded for the GDM, and we also coded for those patients that moved on to medication therapy so that we would have an accurate representation of who those patients were. And then the data was downloaded confidentially. We used our informatics compliance officer to make sure I didn't break any rules, and then we used SPSS to do the analysis of our data. So I just want to talk about the data definitions quickly. The nationality of the patients was categorized as Emirati, which are national Emirates population, which actually is quite small in the UAE. Only about 20% of the country are actual naturalized Emiratis. Gulf Cooperation Council, which are other countries like Bahrain, Kuwait, and then the other nationalities that were included: Indians, Syrian, Egyptian, American, South African, Filipino, and Jordanian. The date of diagnosis was captured as weeks of gestation at the time of the glucose tolerance testing, and we broke that into 24 weeks, 24 to 28 weeks, which is what is recommended by the NICE guidelines, and then those that were later than 28 weeks. And this was kind of a challenge for us because we did have a lot of women who presented late, so that glucose tolerance testing was done late in their pregnancy. And then you can look at the categories for BMI, and we did try to capture that all the way from normal to extremely obese. The education was records of the education was collected everywhere we could find it in the EMR. If we could find it anywhere, then we counted that the education happened, because just like we have in Cerner here, people document everywhere. But if we found it, and we only considered it none if there was absolutely no notes regarding education. And then the demographic data was, the final indicator was collected as the GDM treatment at the time of delivery. So we looked at the time of delivery and whether or not the patients had progressed to oral or insulin. And then the demographics, we considered 2 visits. One of the big challenges we came up against was that the compliance with the second visit, and so we went to telemedicine, and that was very successful. And so if they did have the second appointment as a telemedicine appointment, we counted that as 2 appointments. So these were our demographics. You can see the dark pink is the pre-survey and the light pink is post. You can look at the slight difference in ages. We did see a decrease in our Emirati population in the post-implementation, GCC, and other nationalities. BMI, you can see the number of obese and extremely obese patients, and of course we know that this contributes to that diagnosis. The interventions, so I'd just like to point out a couple of things here. First of all, you can see the big rise in education that patients receive related to lifestyle management and glucose control, and also our referrals to the dietitian. You can see it jumped massively as a result of the dietitian being present in the integrated clinic. And finally, this is the thing I'm most proud of. You can see our pre-study, 48% controlled with diet, and 52% of our patients that went on to medication management for their condition. It wasn't as bad as our original little audit had suggested, but you can see at the end, we ended up with 80% of our patients being lifestyle controlled and only 20% progressing to medication. So we made a substantial difference, and actually that continues today. It's one of their continuing clinical practice guidelines for Joint Commission. Okay, I won't go into all the data analysis for you guys because I'm running out of time. These couple of things, though, I think are important. The results show that gestational age and BMI were the only values that were statistically significant to the model. Obviously, the higher the BMI, you can see the patients who were extremely obese were over 4 times more likely to move on to pharmacological therapy. And then the other thing that was interesting was the increased gestational age. They were more likely not to go to pharmacological therapy. And at first we were kind of confused by that, but then when we went back and did a mini audit, we recognized that that was because actually those older patients were more compliant. Implications for practice, just the multidisciplinary model of care and how that can be extended to other environments. They have moved it now to MFM for maternal fetal medicine clinic, where they see a lot of patients who are type 1 and type 2 diabetic, and it has been very successful. The use of telemedicine, I can't say what a difference it made. We had regular video conferences with our patients when they wouldn't come in, particularly for the second appointment. And obviously, if we had done this as a more longitudinal study, we may have other conclusions as well to add to the literature. Future projects, like I say, expanding it over a longer time, the research over a longer time into other sites. Consider other modes of telemedicine. There's some really advanced maternal assessment work going on now for distance medicine, and certainly they are looking at that. And then the final thing was we did a patient experience survey with this study, which was actually not included in the study findings, but about 90% of our patients said that what we taught them, a lot of it was new information. And so they have expanded the patient experience survey, and they're gathering some really good data from that. So in summary, this presentation introduces a project that improved the care of GDM patients in the UAE. It was a combination of following the evidence-based guidelines and also looking at an interdisciplinary clinic that really worked for our patients. And the target was achieved with only 20% of our patients attending the integrated clinic requiring pharmacological therapy at the time of delivery. So my question, I guess, for people to think about is, are there implications for practice here in the Cayman Islands? Because I can certainly see places where the lessons learned and the demographic that we're dealing with crosses over, and maybe there's an opportunity here as well to improve the care for GDM patients. Thank you, everybody.